All right, this is part 2, going through a series regarding capitalizing on the continuum. So just knowing that there are lots of different levels of care, this module is devoted to understanding that continuum of care within rehab.
Yeah, and remembering we're also talking about catastrophic injury, right? So anytime we're talking about the continuum, many of these individuals for sure are going to hit the first parts, and then, you know, we get down to the second couple and those become a bit more situational. So hopefully today we'll start with talking about what are the levels of the continuum. Brad and I will go through a little bit of detail for each one, and then we'll expand a little bit more on some of the keys along the way, some of the aspects that can lead to trouble, or if navigated well, hopefully it leads to a really great outcome. But so again, with our folks with brain injuries, spinal cord injuries, chronic pain to a degree, limb loss for sure, typically we see the first two levels of the continuum, ICU and acute care. Those are pretty standard, but you can see the next two, post-acute care and community-based, is really where there's a little bit of a fork in the road. But just to start, ICU really is meant for a really highly medical and interdisciplinary approach. These are really very close to injury. And so at this level of the continuum, we're really trying to maintain vital functions, right? They are in a hospital setting and oftentimes very unstable. And we need to make sure that there's no further decline. Hopefully, essentially, we're keeping people alive here and setting them up for the next levels. And then you move on to the acute care level. And in a lot of ways, it's similar in the sense that the medical focus is front and center, but you still have this interdisciplinary approach. And as they stabilize medically, we can start moving past addressing life-threatening issues, and we can begin to, in the cases where there's cognitive issues, physical issues, other complications that might be available, you know, that's something that ends up being a big piece of this. And then we get down to really, as we go through our modules, we're going to focus mostly on the post-acute level and the community-based level. The inpatient side of things is still a pretty common thing at the post-acute level of care. If you're at this level, hopefully you have a pretty interdisciplinary approach. Here at QLI, our post-acute program, we have all the disciplines: PTOT, speech, psychology, nursing, and a whole host of other things that help people get back to life. But, you know, really what we're able to do is because these folks are medically stable, that ends up being even lesser of a focus. And then we're really ramping up on the physical and the cognitive, emotional, and vocational aspects of things. So I don't know if, Brad, you want to talk a little bit more about this part of it?
Yeah, I'm hearing kind of an increase in intensity along the way, right? So if someone becomes a little bit more medically stable, we're able to increase the intensity at which they're able to work too, right? So post-acute care side of things, it really takes a large team of people to be pushing that person forward. And like we often say at QLI, picking up the pieces of life again, putting those pieces together, because it's complex, right? It's not just the physical aspect or the cognitive aspect or the medical aspect. What, like, all of those things are going to run together, and it takes a big group of people to interact well and communicate well, to piece that back together.
Sure. Still highly supportive, right? And then as we look at the community-based level of care, you know, as it suggests, these folks are back at home, could maybe be in assisted living, but they're really out interacting with the real world at this point in time. And some individuals, depending on what their care has looked like up to this point, they still have a lot of aspects of their life to work on. It could be supported by caregivers or family members, their support system to whatever degree, but hopefully they've moved into this continuum in a relatively independent nature. So maybe they're going back to work, volunteer jobs, school, whatever it might be, or maybe they're just simply trying to get through their day around the house and reintegrate into parenting and being a spouse and that sort of thing.
Yep, absolutely. Yeah, that's what I was thinking about. Just like not just the work or community based, but even just in the home, what are they able to do? How do they return back into some of those same roles?
Yeah, and it's all set up by that post-acute level of care, and in some cases the acute level, but hopefully we're envisioning what home looks like, and depending on deficits and whether it be cognitive or physical, that really dictates what they're going to be able to do once they get here.
Mhm.
Brad, you also mentioned this full continuum, and we'll get to the next slide here too in terms of intensity and medical intensity and therapeutic intensity. But before we do that, this really is a more visual take on what the continuum looks like in terms of time. So oftentimes we see ICU, assuming there's no big complications and they move through that. Many of the clients that we work with are going to spend a relatively short period of time in ICU comparatively. They'll get to acute care a little bit longer, post-acute care if they happen to go. We tend to see people up to 80 days or so on average.
Yep.
Could be longer, could be shorter. And then you see the community-based level of care is quite a bit longer, right? Hopefully indefinitely, and there's some considerations there too. But if all goes as planned, this is a pretty standard continuum.
Yeah, so we kind of hit on that intensity piece earlier, right? And as the medical intensity is decreasing, like I said, the therapeutic intensity can really go up. It seems like common sense, right? If someone is just having their life saved, they're going through a lot of procedures, or even just trying to become a little bit more alert after a catastrophic type of injury. There's not going to be a whole lot that you can do. You're kind of in life-saving mode. But as a person becomes a little bit more aware, as injuries, orthopedic injuries, muscle injuries, heal and become a little bit more stable, well, now we can start to work with them a little bit more. And even between the acute rehab setting and the post-acute rehab setting, there can be a significant increase in the level of intensity, purely because of the amount of time that's gone by and the healing that's allowed to happen.
Yeah, some of this is just precautionary, right? So they might be non-weight bearing or have some other considerations that essentially make it so you can't increase the intensity, or they just may not be in a spot where they can participate enough, or even the fatigue and whether it be physical or cognitive is very limiting in that regard. The other thing I think that we see is it's not only physical in nature, right? So as they become more medically stable, certainly the physical component is a consideration, but we can start to focus on the cognitive aspects of life, the emotional and social aspects of life. So we start to look at, okay, what are they going to have to do in the real world? Let's start to introduce those to therapy, and that in and of itself adds to the complexity.
I even think back to some of the learning principles that we talked about in module 1, and the fact that, hey, if we push someone too far outside of their comfort zone, which in this case I think about like too much intensity, too fast, that could push them over the edge to failure too.
So we're talking about timing. We're talking about hopefully that medical component starts to subside, and then really we can ramp up. But there's a lot of decision making that happens in between there. And definitely in terms of how we look at things, having a certain level of expertise and understanding when to push, when not to, I think is really, really important.
Absolutely.
And I think this also leads to this next slide where we talk about predictability. Right at the very beginning, it's pretty volatile in nature, right? So we might even be wondering if the person's going to live, unfortunately, at the ICU level. And if they do live, predicting what's going to happen in the future at this point in the continuum is really, really hard. But as you move through, especially into the post-acute level and even the community-based level, things hopefully are becoming more stable. And then again, for someone who's worked with this population quite a bit, we should be able to make a pretty good prediction as to their level of care. How much support are they going to need? Are they going to be able to get back to work, or what are they going to do with their day? And not that progress stops here, but it again becomes more predictable. So I don't know, maybe you talk a little bit about your decision making once it gets down to these.
I mean, oftentimes you're looking at trend lines, right? So how far post-injury is that person? What does their rate of progress look like? And again, like you said, that could change. It doesn't mean that it's always going to be like that. If someone hasn't made a lot of progress, it doesn't mean that they won't take off at some point after a catastrophic injury. But if they're trending in a good direction over the last 3 months, well, that helps me as a clinician then start to say, gosh, given what they've been doing and the type of injury that they have, here's how I might start making decisions about durable medical equipment, or the amount of help that person or support that person is going to need in the long run, or their potential to return to work or driving or whatever that may be, right?
Yeah, maybe let's talk a little bit more about what we've seen on the good side and the bad side of this, right? So let's maybe look at, if you happen to be at the ICU or acute care level, right? And you have family members who definitely want to understand, okay, what should we expect here? What's your approach there? How do you navigate that? And how does that maybe compare to, I'll say it, luxury that you have at the post-acute and maybe the community-based level? How does that differ? And as a clinician, how do you navigate that?
Okay, so I haven't ever worked in the ICU level of care, but I'm thinking something that I've heard from a number of people over the years is that they kind of get told this definitive answer early on in that process, and that's what kind of sticks in their mind, and it either creates a lot of hope or it makes people really mad. And they want answers up front. And so I think physicians can be put in really difficult positions when they're asked, hey, what is my loved one's life going to look like? What should we be expecting? Right.
Hmm.
And I would caution people to give a definitive answer at that moment, because I mean, we've seen so many people that completely beat the odds, right?
Hmm.
Or they've been told something, your loved one will never walk again. They won't have a level of communication like they ever did prior to, or cognitive functioning, but they completely, again, defy the odds and look totally different 6 months, 9 months, 12 months down the line.
Hmm. Well, and I think really what you're getting at is, how do you provide this level of hope and optimism, but then balance that with being realistic?
Realistic.
And
Yeah.
I do think that there's this certain pressure to make sure that you set people up and help them understand, here's the worst case scenario.
Yep.
And that would be a really hard position. We've been in that position. We just happen to be later in the game.
Yep.
But no one ever wants to be the person that crushes hopes and dreams. And nor do I think we're in the position to do that. I think you and I both take the approach of, look, we don't have a crystal ball. We've seen a lot of folks in your positions. Typically, here's what happens, but we're going to do this, this, and this, and hopefully we can make some progress.
Yeah.
One more thing, let's get back to your decision making about, let's just say, DME, right?
Yeah.
So durable medical equipment. I think of this especially in terms of wheelchair choices, right?
Yeah.
We get that individual, maybe a spinal cord injury, who might benefit from a power wheelchair as well as a manual wheelchair. You and I have seen plenty of times where they outgrow maybe that power wheelchair and no longer need it, or they outgrow both of them if they happen to be incomplete in nature. Yep. And they're up walking around. Talk about, how we make those decisions and the value of waiting a little bit further into the continuum if you have that luxury to do so.
Yeah. So again, back to trend lines a little bit. So let's say that I've had a person that has a lower cervical spine level spinal cord injury, but I know that it's an incomplete injury. Maybe they started out as maybe 50% incomplete, what we would call like an Asia B to Asia C type of spinal cord injury, but they've progressed over the last 3 to 6 months, maybe before they get to us at QLI, to a level that's even more incomplete. And functionally, they've been able to go from just maybe standing with help to starting to take steps, or even taking steps without help too, right? I start to think, well, how far could this person go? Are they at just like a home-based level of walking? Is it a community-based level of walking? Will they need some kind of a power wheelchair or power mobility device to get them around in the community and help them access that, or not? And I think if you're in a position where you're having to make those decisions 3 months after an injury, oftentimes we get lots of people put in that position where they're expected to identify the equipment needed for that individual over the long haul, and someone may come to us with a power wheelchair and leave, and they don't even need a wheelchair anymore because they're up and they're walking and they're on their feet, right? It is a case that we have more incomplete spinal cord injuries now than we ever have because of advances in medicine and advances in response time to those spinal cord injuries too. So it does make that decision-making process a little bit more difficult. But in order for someone to need that chair long-term, they're going to have some level of a need, especially in the community setting, over longer walking distances. Because oftentimes I want people to spend as much time on their feet as possible, as long as they're safe.
Yeah.
Right.
Well, and I think that's the whole point of this, right? If we understand what the continuum holds in the future, then hopefully we make better decisions early on with the best information that we have, knowing that we don't have everything that we wish we would have. We don't understand exactly what's going to happen, and we're going to make some mistakes along the way.
Yeah.
Hopefully we keep learning from that. All right, so level of support contributes to this as well. So just as the volatility and predictability is extremely low, they're in situations where the support is really, really high, right? So they're in a hospital setting, they're with physicians, there's nurses right down the hall. And if there's a medical emergency, there's quite a bit of support with that. And as a result, right, people's abilities can be masked, or what they might look like in a really structured formal setting may not be predictive of what they're going to look like in the real world. So the nice thing about moving through the continuum is that the support hopefully decreases.
Yep.
And we can start doing things out in the community outside of a really formal hospital-based setting, and we get a really clear look at what someone can look like. So let's talk a little bit more about what does that look like at the post-acute level, and maybe what does that look like at the community-based level, and how are they the same or different?
Yeah, I mean, just thinking about the level of support needed at a post-acute care level, we touched on this earlier. At QLI, we have PTOT, speech, nursing, psychology, some physician support, life care, life skills, life path services. So there's a number of people that are touch points there. And again, trying to piece the person's life back together, give them a vision and help them get some ownership and autonomy over life again, because people have had a lot of control stripped away from them, right? And then the ultimate goal is that, hey, when we get to that community level of care, it's you driving a lot of that as the individual, with maybe your close support system. Maybe that's a spouse or friends or significant other that is involved with you, children, and then your medical support team that's there, but it's more fragmented and not seeing you on a daily basis.
Well, and I think it's a constraint in and of itself, right? Because there's this level of support, and as providers, when we work really hard to start to scale it back, and so that we can get a really clear picture of what this person's going to be able to do, and so that that person and their network can get an idea of what's going to be needed when they get home. But if we don't do a good job of, call it simulating, but even simulating is not really all that realistic, because we can't simulate spontaneity. We can't simulate random things that happen in our
novel tasks, right? Yeah.
We can't simulate that. Because we can't simulate that, there's going to be a gap, even if we do a really good job of that.
Yep.
So I think that's a really big piece of this is that we want to decrease the support appropriately. We want to integrate the challenges that are going to be faced once we get to the community-based level of care, but we have to be prepared that we're not going to get quite there. There's still going to be a percentage that we're going to have to see and we're going to have to respond to.
Yep.
All right, so we talk quite a bit about what a therapy team looks like, from ICU really through a post-acute program. It's pretty extensive, and we've already mentioned that the support is really, really high. Typically, these individuals are all at the same setting. So obviously the injured person, we have injured worker here. We deal a lot with work comp. The support system is going to be available, any sort of care coordination, if that happens to be available, and then all of the medical professionals that are involved here. There's a couple different ways to look at this, but with the types of injuries that we deal with, we recommend a center of excellence of some sort, right? And typically there are centers of excellence at every level in the continuum. It gets a little bit harder to find it as you get further down the road, but we highly recommend that, given the level of expertise that it takes to navigate these types of situations. And you're going to find, for the most part, each of these disciplines at those centers of excellence. But once you get past the post-acute level, an interdisciplinary therapy team is oftentimes a bit hard to find. And we've pictured the ideal scenario. This isn't always the case, but hopefully the injured person and their support system are really closely tied to each other, right? They might be in the same city, or they at least have a good working relationship, and they have supports in the fashion that they need in order to be successful. Granted, this isn't always the case, and it looks very different from person to person, but this is the ideal. And then they're going to have some physician support on board. the specialties of those physicians is going to vary depending on their cognitive or physical abilities or whatever else they have going on. And then we've just outlined PTOT, speech, and psychology here. It could be nutrition. This certainly isn't meant to be all inclusive either. But if you can get those PTOT, speech, psychology like disciplines all in one setting or all with a team that's working really closely together, we believe that the outcome is the best in that scenario, because there's a high level of collaboration and communication that needs to happen. You work on a therapy team. Talk a little bit more about what that looks like for you.
Yeah, I guess in my 11 years of being a physical therapist, one of the things that I've appreciated the most, both working at QLI and also in Kintinu Telerehab, is not the fact that I'm not on an island as a provider, right? I get viewpoints and I get perspectives from my occupational therapist, the psychologist working with the individual, speech therapist, and like having a few more heads at the table. Mm-hmm. Always, I think, leads to some better outcomes, right? There are cases where, hey, it's just one discipline with a person working, especially on the telerehab side. But I love not working on an island and being able to work together in a team to make sure that we're looking at things from all different angles.
Mm-hmm. Well, and allows you to be really nimble too, right? Yep. So having regular, call it team meetings throughout the week, I wouldn't say is the norm at the community-based level. No. We see it quite a bit at the post-acute level, right? You have weekly meetings where we're planning and things are moving very, very quickly. Thankfully, they slow down a little bit at the community-based, but I do think that having those meetings allows the therapy team to keep everyone informed, right? Here's where we're going. Here's how things are progressing. And if there's challenges or opportunities to push the limits a little bit, we can respond to that very, very quickly.
I even think like within our telerehab team, there are times where our psychologists will inform me of something that's going on with the individual that they may not tell me, right? And that's not breaking patient confidentiality. It's just like, hey, so-and-so mentioned that this is going on with a brace that they have. Would you mind just checking in with them to make sure that that's okay? Or the occupational therapist, being able to say to the occupational therapist, hey, this person seems like they might be having some issues, maybe reintegrating into the community and maybe even like vocationally getting back to volunteer opportunities. What do you think about helping them with that?
Yeah, I mean, I think the other component is from a learning perspective, right? How many times might they be out in the community and they happen to be with the speech therapist or the occupational therapist and they're working on mobility and walking and whatever else they might be doing out there, and it's an opportunity to be supported by someone who understands, like, oh, I know Brad's working on this, and how can I be supportive of that and add a few repetitions of that along the way. So we boost the intensity of the program just by having some collaboration along the way.
Yeah, and I think my care is made better by having those teammates around me.
Absolutely. So really unique component, I think, to our program. And if you don't happen to make it to our program, I think it's just something that you should look for. Into. Yeah, for sure. Okay, so that wraps up our module number 2, and obviously we have a couple more to go to, but hopefully by the end of this our listeners can understand, hey, here's the different levels of the continuum, here's what's important at each level, here's a few things I should be looking for, and hopefully the other 2 modules we have coming will support this one. So thanks again for joining me today, and always fun to not have to present on my own. So
absolutely.